Good evening, everyone. Welcome to another session for the KMA weekly webinars. My name is Dr. Warda Quresh, a mental health advocate, member of the Physician Wellbeing Committee. Today, we're going to be discussing sleep and mental health. But before that, I'd just like to invite our KMA CEO, Dr. Brenda Obondo, to give us a few welcoming remarks, a few words, and then we'll be able to get the session going.
Thank you, Dr. Warda. Good evening, everyone. Kenya Medical Association warmly welcomes you to this mental health webinar series. Today we'll be tackling sleep and mental health. This webinar series is brought to you in collaboration with the Kenya Clinical Officers Association, the Nurses Association, KMPDU. So we're excited to bring this to you as healthcare workers for healthcare workers in support from Equity. So we look forward to taking care of our mental health and prioritizing our mental health as healthcare workers. Please join us every Thursday for this month and every Tuesday from 7 p.m. so that we can learn and we can see how best to prioritize our mental health. So over to you, Warda.
Thanks so much, Doc. So now I'm going to invite Dr. Neema Haraka. She's our speaker panelist for the day. So Dr. Neema is a psychiatrist at Fitahi Consultancy Clinic. Her main focus is on preventive and promotive mental health care. Her core skills and expertise lie in behavioral therapy and psychotherapy. She helps clients with stress and anger management, insomnia, managing distractions, self-esteem, social anxieties, identity crisis, emotion dysregulation, grief, loss, loneliness. Additionally, she also does liaison psychiatrist at the Endometriosis and Surgical Center and also at the Comprehensive Diabetes Clinic. So before I welcome her, I'd like to urge you all to post your questions in the question and answer section, engage within the chat section so that it will be a very productive discussion. So let's go ahead and give it up to Dr. Neema.
Thank you very much, Warda. Good evening, everyone, and I hope you've had a good day. So our discussion today is going to be about sleep and mental health. And my very first recommendation to all of you, my colleagues, is to make sleep your doctor's apple every day. To keep, going to the doctor. So I'm Dr. Neema Araka, I'm a psychiatrist at Fitahi Consultancy, and our objectives for today are going to be what is restorative sleep? So trying to define it, what disrupts it, what are the effects of disrupted sleep, and how sleep affects physician performance. The presentation is going to be very brief because I'm hoping that we can have an interactive discussion, since sleep is a really, really important topic, very vital to each one of us. So there are experts perhaps in the discussion who may have more to offer or something to recommend to ourselves to be able to do better in prioritizing sleep. So getting to the definition of sleep. In the literature, there is no agreed upon definition of what restorative sleep, but I was able to find a consensus on what non-restorative sleep is, which is a subjective evaluation of feeling unrefreshed after being able to get the opportunity to sleep and being able to get the time to sleep. So you have a place to sleep, you have the time to sleep, but you wake up feeling unrefreshed. That is non-restorative sleep. Sleep is a biological imperative, meaning each one of us requires it. And public health professionals recommend that we get 7 to 9 hours of sleep a day. Sufficient sleep, according to CDC, is not a luxury. It's not something you can bargain with. It's vital for good health. So we all need sufficient sleep. I know as doctors, we will say that this is not possible. I've had some discussions, and the feedback is that for a doctor, 7 to 9 hours is not reasonable. So I hope the discussion part is going to help some of us sort of find our way to get that sufficient sleep. So what is restorative sleep made of? What are the qualities? And today we're just going to look at 3 main qualities. Of course, there are more. So number 1 is the duration. The length of sleep should be sufficient for the sleeper to be rested and alert the following morning, refreshed, rejuvenated, ready, and alert to take on the day. Duration is going to differ from individual to individual. Some people will claim that they're able to sleep 6 hours a day and they are functioning very well, they're performing adequately. Others would say that they need at least 8 hours of sleep, and that is affected by different factors. So the genetic factors come in, behavioral factors, environmental factors, social factors will affect how different individuals require different amounts of sleep or duration in a day. Continuity and depth should be the same. So if you're sleeping 6 hours or 7 hours or 8 hours, there has to be continuity, no fragmentation, no disruptions, no waking up. So from the beginning to the end. So that's why sleep hygiene becomes important, to prevent that. That is really important. Depth, you should be able to get deep enough sleep. So whether that is 4 hours, 6 hours, or 8 hours. And these factors vary from individual to, for example, behavioral. What an athletic person requires to perform in the day is different from what a teacher maybe requires. And that's why elite athletes tend to have what they call sleep extension. So they do at least 10 to 12 hours of sleep in a day to be able to increase certain performance indices in their performance. Now, looking at what disrupts sleep, and I've tried to make it very relevant to the nature of our work. So number 1 is the circadian misalignment. Because of the nature of our work, the extended working hours, the length of the shift, the overnight call duties, the irregularity that we get in a day really misaligns our circadian rhythm, which is the first reason why sleep gets disrupted. Number 2 is the inadequate recovery sleep. So if you've worked perhaps an 18-hour shift, then how do you recover that? How adequately do you make sure you recover that sleep? Unrecognized sleep disorders. Many of us may not be aware that we're having a sleep disorder. Perhaps because you're a doctor, you'd find yourself not sleeping and easily prescribe yourself or get an anti-anxiety, a benzodiazepine to help you sleep. And you don't think that's a sleep disorder problem that requires medical attention. But when you find yourself struggling to get sleep in a week more than 2 times or 3 times, that should make you concerned enough to say, I need to see a colleague or I need to see a doctor. In this case, you put yourself as a patient to say you need to see a doctor to be able to understand why you're not sleeping, because the benzodiazepine is going to give you that sleep, but the cause of that sleep, of the insomnia or the disrupted sleep is still going to be there. So after you finish using the benzo, the disrupted sleep, the disturbed sleep is going to resume, to return, and you run the risk of becoming dependent on the benzodiazepine or developing, or if you decide to remove it, then you're going to get the withdrawal symptoms over time. So in any case, you do run the risk when you self-medicate, when you're not sleeping well. So looking at some of the unrecognized sleep disorders, this is not particularly a sleep disorder, but it does give a number of people some problems. Sleep paralysis is like the locked-in syndrome. So your brain is completely awake, but your muscles can't move. And this can really make you anxious because you spend a few minutes where you try to speak, but you can't. You try to move your hand and you can't, but you're there. And you might get afraid of falling asleep because of sleep paralysis. I know there's been attribution of witchcraft, and in our setting, we do have that a lot, but a lot of us do experience it. Literature has not really given us a cause for this or what risk factors contribute to this, but stress has been shown to have an association with it. The other one is hypnagogic hallucinations. This is when you're falling asleep and it involves the senses as well. So you literally hallucinate, you see things, so your sensory perceptions are disturbed, but it does not, it does not make you at risk of developing an actual psychotic episode. 70% of people experience it once in their lives, and it has no consequence in their mental health. So when these things happen, and then you go and medicate yourself so that you don't get to feel this phase, when you could have actually spoken to somebody who would have reassured you, that would have helped with sleeping more than the benzodiazepine. The other one is when you're waking up, hypnopompic, which involves mostly visual hallucinations, so you see things, and 34% would involve auditory hallucinations. So like a psychotic episode, but not a psychotic episode, because you come out of it in a few minutes and you're okay, and it does not mean that you're at risk of developing a psychotic episode. So what are the effects of sleep deprivation? As we can see on the blue side, this is mostly for physicians. So there's increased risk of burnout, and it reduces your personal fulfillment. It increases the rates of self-reported medical errors. These are some of them. We'll look at one most fatal one that tends to happen to us as well as doctors. So sleep deprivation, looking at this person here, you increased heart rate variability, you have a risk of heart disease. All these things, as doctors, we're aware of, yet we are the most sleep deprived professions in the industry or in the field. Cognitive impairment, irritability. So I would just like to do a quick poll and see, or survey, how many of us are aware of our irritability when we're sleep deprived? Raising hand would be okay, or saying yes is okay as well. Okay. Okay, so the next question, perhaps we can stop there. The next question is, how many of us are aware that our irritability affects how we interact with people in that particular day. And it makes their mood also bad. Okay. Yes. So these are the effects of sleep that we encounter even on less than 15 hours of not sleeping in a day. So the next one is where we come to. The other thing, before I got to the next one, is that not sleeping, you see that oath that we take as doctors, do no harm. Not sleeping affects our neurobehavioral systems. And so it threatens that fundamental professional mandate that we're given, to do no harm. Yes, so that is sleep. And this one now is really important. When you don't sleep for more than 24 hours, it's equal to having blood alcohol levels of 0.1%. That's above the limit for driving legally. So you're driving drunk. And here is a question that I want to see the response. How many of us as doctors, at any point in our careers, at any point in our jobs as doctors, have driven home after a shift of 24 hours without sleeping? Yeah. This is quite sad because we tell people do not drink and drive, yet we as doctors, we are not exception to this. We are human beings, so not sleeping for more than 24 hours is equal to having the blood alcohol level that is above the driving limit. And I know that some institutions are making recommendations where the hospital allows for a break of about 6 hours of sleep in a 24-hour shift, either within the hospital or out of the hospital, so that a doctor does not go the exact 24 hours without sleeping. And even if they do, then they're not allowed to drive home by themselves, because that is a risk of road traffic accidents. So we can see here that when we look at road traffic accidents, drivers who sleep less than 6 hours are 33% more likely to get involved in road traffic accidents. And here we have more than 24 hours, which is be above the legal limit of driving. WHO says that at least 1.3 million people die due to road traffic accidents. 93% of those fatalities result from middle to low income countries, even though we don't have as many cars as high income countries, which is quite paradoxical. But again, here we're looking at other factors like, the infrastructure and things that may not be in our control. 3/4 of drivers who cause accidents are males under 25 years of age. And when the blood alcohol level is taken, it's usually between 0.04%. So that is equivalent to a person being awake more than 17 hours. But you see here, you have doctors driving on the road, having not slept for more than 24 hours. I'm hoping that can be a discussion that can be raised so that we can reduce these risks for our own fraternity. Now, looking at sleep and depression. Sleep has been shown to, deprived sleep increases the risk tenfold for anxiety and depression. But looking at depression here, the common reason why people seek care is because they have trouble sleeping. And 75% of those who are depressed tend to have disturbed sleep. So on the depression scale, I think number 3 or 4, we ask you, do you sleep a lot or do you sleep less? 75% say they don't sleep a lot. I mean, they have problems sleeping. 40% say they sleep a lot. Both of them are symptoms of depression. And not sleeping or disturbed sleep, deprived sleep, is a strong risk factor for suicidal ideation and behavior. And so correcting sleep is really important for any patient presented to you, whether due to depression, due to anxiety, due to schizophrenia. With depression, when you don't correct sleep, you can do CBT successfully, but then it's not going to have a positive response. You can give antidepressants, and we know a lot of depressants actually work against sleep. So you really want to tackle sleep on its own to see how that can reduce the burden of the disease, to see how that can, help better the symptoms in the disease or the quality of life. There's increased risk of recurrence when you don't sort out the sleep when you're treating a patient with depression. And of course, the quality of life declines. So correcting sleep in mental illnesses is really critical. It should be primary. So how does it affect physician performance? The results on this have been mixed and inconclusive, because majority of the studies would say that it impairs mood and cognitive function, and others would say that it doesn't impair cognitive function, but it impairs mood. So there are a lot of studies, but there's none that give, they have not reached a consensus to tell us that this is one answer that we're getting for performance that is influenced by sleep for physicians. Now, one study did say that sleep disturbance does impair the mood and cognitive function with limited personal insight. So the doctor is not aware that their mood has been changed by the lack of sleep. And so they go around perhaps thinking that their mood is okay, and it's the other people who are not receiving that doctor well. It's the other people that are not maybe responding well to him. There is limited cognitive function, and again, with limited awareness. You're not aware that the sleep has affected your ability to function well, to think properly, to make, proper diagnosis and proper treatment plans. The impact of sleep. One study did an experiment on surgeons. So this was on animals, and they're looking at surgical dexterity. So what they found is that when surgeons were put to sleep for less than 2 hours, they had poorly planned maneuvers exceeding 30% of the operating time. So if they could have taken maybe an hour to do a cholecystectomy, they took an hour and a half or 2 if they have not slept. And then this is for anesthesiologists. So we look at the shaded circles. I think I can get a pointer. So this is deprived sleep, and this is sleep extension. So you can see, as the more deprived they get, the poorer they are at performing. PVT is psychomotor vigilance task. So you can see that they take longer and longer, but when you sleep sufficiently, then you take a shorter time, your response time is faster. Yeah. So what can we do to improve sleep? Sleep hygiene has always been a first-line recommendation, and these are some of the things. I think one of the things that I would say work for everyone, because we need them, is avoiding large meals close to bed and switching off devices 1 hour before bed. This is really important, because the time you spend answering to messages or leaving your phone to have notifications such that you've fallen asleep and then you get a notification, you don't find it bothersome at the time, but then after you wake up to see the message, you're not able to go back to sleep as quickly as you should. And those fragmentations affect your quality of sleep, which in turn affect the restorative nature that we need for sleeping, making your room dark, keeping your room cool, avoiding stimulants after lunch, meditating. These will vary from person to person. People who can take coffee at 7 or at 4 and still they're able to sleep. So best sleep hygiene vary from individual to individual. You want to make sure that when you go to bed, you get uninterrupted sleep. There's continuity and there's depth in your sleep to be able to be restored. My personal recommendation to improving sleep this year is no excuse should excuse you making your bed every morning. And this one does not have to be a chore. It can be an activity that you do with your partner. Every morning, this can be a keystone habit that you develop. You don't have to do it well. You just have to start doing it. Spread your bed, make it neat, the first thing you do before you go to the bathroom, before you brush your teeth. What this does is that it gives you a sense of accomplishment, that you've achieved the first goal of the day. So that sets a chain of reaction for more productive activities that can be done. And some polls have been done by different companies to look at the benefits of making your bed every single morning. Charles Duhigg, in his book, The Power of Habit, said, making your bed every morning is correlated with better productivity, a greater sense of well-being, and a stronger skills at sticking with a budget. It's not that a family meal or a tidy bed causes better grades or less frivolous activities, but somehow those initial shifts start a chain reaction that help with other good habits. A poll done by National Sleep said that those who make their bed every single morning are 19% more likely to get better sleep at night, and 75% more likely to change their sheets so that they sleep on clean sheets on a regular basis, which improves the quality of sleep. It takes about 18 to 54 days to form a habit or to make a habit automatic. And you could start that with making your bed. In 2 to 3 months, that becomes an automatic habit. So it no longer requires motivation or discipline. You just do it because it's part of your day and it's become part of your routine. And lastly, I would like to leave you with a quote by Frank Knight, who says, "Never waste any time you can spend sleeping." Thank you very much for listening. And we can move on to the Q&A. Thank you, Dr. Warda.
Thank you so much, Dr. Neema. That was very insightful. I know as physicians, as medics, as healthcare workers, we all know this and what we're supposed to do, but the nature of our work, as you said, forces us sometimes to go above these limits. But hopefully with this, we'll be able to better advocate for ourselves, even within those 24-hour shifts, to be able to get a few moments of sleep so that we can also not inconvenience the patients. So before we go through to the question and answer session, the panel that you're seeing right now is on-call support for healthcare workers. This is an initiative that is brought about by KMA, KMPDU, Equity, and all working towards healthcare workers supporting one another when you need support. If you need support, even if you don't think you need it at the moment, these are the numbers you can call. There's also a toll-free number that was shared, but we'll share it in the respective KMA groups. So now we can head on to the question and answer session for a bit before we wind up. So for Dr. Neema, we're being asked, are there any herbal supplements to help with sleep?
Dr. Warda,
Nam?
I can see Dr. Simon's hand is up.
Oh, that was still from the poll.
Ah, okay.
So we can proceed. Are there any herbal supplements to help with sleep? And then the next question is on the effect of progesterone and hormonal contraceptives on sleep in women using this form of contraceptives. And yeah.
We can do one at a time, yeah?
All right.
Okay. I'm not aware of any herbal supplements that have been studied to help with sleep, but I know that there are some studies, I don't know about their credibility, that eggs do help with sleep. Like for your dinner, having 4 to 6 eggs, some have even gone as far as saying 8, can really help with sleep. Of course, other things have to be done as well. So adequate exercise, being active in the day, sleep hygiene, that is getting ready to sleep, telling your body, sending that message to your mind that you're going to sleep. So you dim the lights, you reduce the blue light from your phone. That's why you switch it off to increase the production of melatonin that is required for sleeping. Yes.
All right. Next, if there's any effect of the hormonal contraceptives like progesterone on sleep in women using that form of contraception.
This one, I'm honestly not sure. If there's a gynecologist in the house, I'm not aware about this.
I think anyone who will be able
Maybe
to assist,
answer it, yes.
yeah, can answer within the chat. I'll open it up for the panelists and the attendants at the end.
Okay.
The next question was on any relation between sleep deprivation and hypertension.
Absolutely, yes. I think I'll go back to that slide. Sleep deprivation does put you at risk of hypertension and diabetes and osteoporosis because of the increased cortisol production, yeah? So it really impairs your immune system. So yes, definitely.
Question about the gap relationship between sleeping during the day and during the night.
This one varies from individual to individual. There are those people who work well by taking a nap in the day, which some literature has shown that is equivalent to, so 30 minutes in the day or 1 hour in the day is equivalent to 2 hours or 3 hours at night. And I see some people using this principle to increase the hours in the day. So this will vary from individual to individual. There are those who, when they take a nap in the day, then they can't sleep at night or they have trouble falling asleep at night. So when you're able to know your own biological clock in terms of sleep and wake, then you can practice this.
All right. There seems to be a few people who joined after you had started. So there are a few questions on the minimum hours that one should sleep per night.
That's okay. Per night, public health officers are recommending 7 to 9 hours. But like I mentioned, this will vary from individual to individual based on a number of factors, genetic factors, behavioral factors, social factors, yeah. So some would say, I feel sufficiently well slept on 6 hours or 7 hours or even 4, although I think 4 is really, really inadequate. But yes, 7 to 9 hours is adequate to sleep, according to public health officials.
All right. Well, a question on the use of melatonin for sleep, especially after night shifts. That is regular prescription use or regular and prescription use of melatonin.
Whether they should use it or not.
Yeah, especially after night shifts.
Yes. I think that again would be from individual to individual. If after night, you see the circadian rhythm is your body getting used to a regular sleep-wake cycle. So when you disturb it, which we often do as doctors, then sometimes you need to give that some time and adapt to the new rhythm. But again, that changes again. So, and that is my point of discussion, especially for the senior doctors here. Because how long can you use melatonin when you keep disrupting your circadian rhythm? That means you'll be dependent on it and need to find ways to create some consistency in your sleep, which is really key to the overall quality of sleep that you get. So for that one, I'm not very sure how to answer it because they need to sleep. And if they're having trouble sleeping, then melatonin would be helpful. But for how long? What will be the long-term plan?
Okay. And we have one on why do menopausal women or menopausal women have insomnia?
Oh, there's a menopausal rating scale that in which one of the symptoms is insomnia. And then menopausal women, they have a double risk because menopausal symptoms, insomnia is one of them, and then they're at risk of getting depression, and depression has insomnia as one of the symptoms. So here it's the state of menopause that can cause insomnia, but it could be maybe a depressive episode that is starting that could be causing the insomnia. So it's good to get evaluated and to see if they have other symptoms out of the menopausal symptoms that may be contributing to the insomnia so that you know how to treat it. Because if it's because of menopause, I think a gynecologist can handle this. And usually it's because of the declining estrogen. So the approach to treatment will be a bit different from when depression is involved in menopause.
There's one on how to help pregnant women with sleep problems aside from sleep hygiene and having eliminated or treated all pathologies and comorbid conditions. So in the pregnant women.
Yeah, that's a difficult one. I've had a client and it was really hard because we could not find the source of why the client was not sleeping. It was not the position, it was not the food. And when I read the literature, there's an impasse that you get to with insomnia or with sleeping problems where you've tried everything and it's not working. So there, I don't know if you've tried everything. Even in literature, they say that you reach a point where you feel defeated because there are no other interventions to use. And with pregnancy, you're limited with medication as well. Yeah.
There is a question on whether there is a correlation between cancer and lack of sleep.
I don't know.
There is an answer that has come up on the use of the contraception from one of the members. The answer is that progesterone has sedative effects. So if taken at night, ladies tend to sleep more. All right. Okay. One of the last few questions, they kindly expound on the effect of alcohol on sleep.
Yes, alcohol on sleep, it completely destroys the architecture of sleep. Those 4 stages, alcohol really destroys those. Now, you see, alcohol has got many reasons why people drink alcohol. You drink alcohol when you're happy, you drink alcohol when you're getting married, when you're graduating, you drink alcohol when you're sad, when you're heartbroken, when you're rejected. So use of alcohol is multifactorial. And for people who use alcohol, because stress tends to build up and then it starts affecting your sleep. So in effect, when it affects your sleep, you use alcohol to help you with sleep, but really it helps perhaps with those stressors because of the effects that it has. It's a benzodiazepine of some sort, isn't it? So it quiets things down a bit, but on sleep, it definitely ruins your sleep. And so you realize that people who take alcohol in the evening, they might go to sleep, but they struggle with getting restorative sleep or even falling asleep or staying asleep. This is according to literature, not my opinion. So it definitely does not help with sleep. If anything, it makes it worse.
In addition to that, there is a question about what will happen if somebody uses amitriptyline after long shifts, if there is any side effects to regular use of amitriptyline and any other medications.
Amitriptyline, it does help with sleep better than SSRIs. Long-term effects, I'm not very sure, but when it comes to sleep, I would always say, try and identify the cause of not sleeping, because often you can. It may be a stressor, something at the back of your mind, or something in front of your mind that you're finding difficulty dealing with. And so talking to somebody may be helpful, not necessarily a therapist. It can be a stranger or a friend that you trust. If you don't have a friend that you trust, then you could try a stranger. Yeah, but find the cause of not sleeping, because how long will you use the amitriptyline until the stressor goes away or until you deal with it? I don't know, but I would always encourage that you find the cause of you're not sleeping. What is making you not sleep?
Okay.
Oh, in this case, it was the night shift, was it?
Yeah, it was the night shift.
Oh, yeah, that one, yes. Like I said, this is a discussion now for the seniors to really help us with guidance, because I'm really not sure how to go about that. You have to work to make a living. I mean, and some institutions are not very flexible in understanding that you need to sleep. So how do you deal with that? I really don't know. But for the other cases, it's very important to always just find the cause of not sleeping and then tackle it. Then you're able to go back and establish your sleep routine, your sleep pattern, your very good sleep profile, and that will help.
All right. The second last question, if one can develop phobia from sleep paralysis.
Yes, they can. And that is one of, because somebody might find it very strange and perhaps unique to them, and maybe a bit shameful or embarrassing to tell somebody else about it. So they might become dreadful when the night comes and it's time to sleep. So when you talk to somebody, a psychiatrist would be able to explain it to you and reassure. It's a sort of dissociation that happens, but has no long-term consequences. There are no complications from that. So yeah, a person can develop anxiety from that, which is unfortunate. Yeah, but when they seek help, they can be helped.
All right. There's a question on why some people wake up tired after they have slept enough hours, or even if they think they've slept enough hours.
So I'll give an example of depression. I'm not saying that that is a classical case of depression, but you see, on our number 4 or number 3, I get them confused. We ask you about sleep on the PHQ-9, yeah? And we say, do you sleep a lot or do you have trouble sleeping? So when you sleep and you wake up feeling tired, then that is not restorative sleep. You want to look at fragmentation. Was it continuous or did you have interruptions? And interruptions here could be sounds that perhaps you woke up in the morning and you didn't remember that you actually woken up by sounds. It could be movement. It could be something that happened in your environment or something that you remembered perhaps that woke you up. So the quality of your sleep is really important. Was it deep sleep? And then that makes it restorative. So if you wake up feeling tired, then that means the sleep was not restorative. So you'd want to really look at your sleep audit and see how the quality of your sleep was.
All right. The last question is whether the minimum duration of sleep varies with age.
Yes, it does. I think I can't remember the exact number for children, but it's usually about up to 12. For adults, I know it's between 7 to 9. And for older adults, it's a bit less than that. So between 6 and 8 or 7 and 8. I'm not exactly sure of the numbers, but it does vary with age, yes.
All right. And the last question, whether what is the effect of intermittent sleep for breastfeeding mothers?
The first 2 weeks after delivery, you have the postpartum blues, yeah? And it's usually attributed to the change in your circadian rhythm, because now you sleep according to your baby. And then after that, if it persists, then after a month is when we can start entertaining the diagnosis of depressive episode if the symptoms are persistent. So women are known to be quite resilient when it comes to the sleep patterns with having a baby. And a lot of women don't get affected, but most women do. And the problem is that they don't come out to complain about it or to talk about it. So you can see it in the bad mood, how they handle the child, yes? We tell mothers to sleep when the baby sleeps, but how long does the baby sleep? And I think having help is important for you to be able to get restorative deep sleep of about 6 hours, such that someone is able to help you take care of the baby and you take turns, yeah, to be able to pay that sleep debt that you've incurred while taking care of the baby. The intermittent doesn't really work. And I think mothers know that because they're more irritable when they're not slept. And then other things also don't seem to work. Breast milk reduces, and then they maybe blame themselves. So sleep is really, really crucial. It's vital, yeah. And if mothers can find a way to, have some support that allows them to get at least the 6 hours of sleep, I think that would be helpful.
All right. So before I open up to the panelists in this webinar, I'd like us to take a moment of silence, at least a few moments, just to remember and to think about our colleague, Dr. Fred, who passed on at the beginning of the week. Okay, may he rest in eternal peace. So I'd like to welcome members of the Kenya Medical Association Board, the President, Dr. Kigondu, Secretary General, Dr. Diana, convener of KMA Physician Wellbeing Committee, Dr. Melanie. Should just get ahead and give us a few words so that we'll be able to proceed.
Thank you very much, Dr. Nudin, and thank you, Dr. Araka, for the webinar this evening. And thank you everyone who has attended the session. We continue reminding you that we have this session of the webinar every Tuesday, and we also have our debrief session every Thursday. And we also continue reminding all healthcare workers that it is okay not to be okay. Please reach out, seek help. We are here as the Physician Wellbeing to help all healthcare workers, not just doctors. So please reach out when you can. Thank you everyone for your attendance. I will invite Dr. Marion. You can say hello if you have a word, and then Dr. Kigondo, you'll close for us, and we're done for today. Thank you.
Thank you, Dr. Melanie. Thank you, all the panelists. This was really a very needed discussion. I've learned a lot, except that I could say that I've picked a lot of things that are interacting in terms of how do professionals in the medical field really get to solve this? How do they get to sleep as it is required and still continue to serve their patients safely, such that they don't do any harm to them? How do we communicate that these long shifts are a danger not only to the healthcare worker, but also to the public? How do we bring this out? I know Dr. Araka has brought it out clearly to us as professionals, but how does this get communicated to the stakeholders? The stakeholders that employ healthcare workers, the public itself? How do we get it out there? Such that then these are working conditions, such that we are able to work in environments that are sensitive to the importance. It's a issue, and have a lovely.
Thank you, Dr. Diana Marion. Dr. Kigondu, you can say a word and close for us for the session. Thank you.
Yeah, thank you very much. And I won't say much. The Secretary General has summarized, and I just ask us that we go and sleep. Thank you very much.
Thank you, everyone. We can leave at your own leisure. Thank you.
Thank you. Have a good night.